Hello class, this is Professor Streb and I'll be going over Unit 7 this week. We are talking about care of the patient with common elimination gastrointestinal problems. If you look in your syllabus, it covers these topics. We have GERD, the hiatal hernia, IBD, gastritis, peptic ulcer, gastric cancer, IBS, herniation, obstructions, peritonitis. You kind of get the gist here. We kind of go down the list. These are all the things your syllabus say you need to know in order to be successful on this exam. So we will cover each one of these on the slide as we progress. GERD is the very first thing on the list of your syllabus. GERD is the most common upper GI disturbance in the United States. Typically in middle-aged folks. We know this is just a backflow of stomach contents into the esophagus or regurgitation. Risk factors, as you can see on the screen, include foods like caffeine, alcohol, spicy foods, fried foods, chocolate. You kind of get the gist there. Those are the foods you need to kind of avoid, if you will. A lot of this is due to diet and exercise. We know this. Patients who are overweight or have obesity are a higher risk for GERD because of the increased weight increase, and the intra-abdominal pressure starts to go up, and that causes reflux. A really big thing that we found out in recent years is that H. pylori also contributes to reflux by causing the gastritis, and then thus the poor gastric emptying. So that's kind of where we're at. But what do we do as a nurse? What is our job as a nurse? One of the biggest things we have to think about is teaching our patients. Explain that large meals increase volume and pressure. Recommend they eat 4 to 6 small meals each day versus the 3 big ones. Have your patients chew slowly and fully to ensure that they can get everything down and avoid belching. They should not eat at least 3 hours before going to bed because that will make the reflux even worse. We know that it can start to radiate to your chest, feeling like chest pain. So we get a lot of people coming to the ER who have chest pain related to GERD. So these are things that we have to pay attention to. We know that GERD symptoms are further exacerbated when you lie down or if you're in the forward-leaning position, so like you're bent over or in a stooped position. Those type of positions will cause you to have more regurgitation and could lead to aspiration or bronchitis even. So your big thing on GERD is going to be teaching patients what they need to do in order to avoid some of the signs and symptoms, what they can do at home to make this better. The next thing we have is called the hiatal hernia. When you're thinking about a hiatal hernia, what exactly does that mean to you? This is where part of the stomach protrudes through the hiatal opening there, through the esophageal hiatus into the chest cavity. So it causes pain, right? It could also cause gastric content to spill into the lungs, which is what we're really, really worried about. So there's a lot in the chapter that talks things to talk about with hiatal hernia, but think about what your main job as a nurse is. You're going to be doing your assessing. We know this already, right? We know that patients who have hiatal hernia often are like people who have GERD, that kind of the same treatments, avoiding some of the spicy foods and, tomatoes and all that acidic type fruit and vegetables. Anything that can trigger heartburn, those should be avoided. Lifestyle changes is having the head of the bed elevated when they sleep to allow gravity to prevent that acid from refluxing into the esophagus. So these are things we have to worry about, because what are we really paying attention to? We're worried about contents of the stomach spilling over into the lungs. How would you know if that happened? You would do your assessments. Typically what you would hear is wheezing. So we talked about this in lab. You talk about your bronchial breath sounds, bronchiovesicular and vesicular. You'd be listening over the bronchial area for some kind of wheezing. And those high-pitched noises could be a note that there's some kind of obstruction in the upper airways. So that's really what you're going to be looking for and focusing on the patient who has hiatal hernia. Some of the things you can teach them as far as it's very much like GERD, avoiding the large meals, small frequent ones, sleeping positions, and then paying attention to like that wheezing sound. Those are definitely some things you have to pay attention to. The next thing on our list is gastritis, which is just an inflammation of the stomach lining, the gastric mucosa. It's something that we have going on. It could be caused by multiple things, but what we're looking for in gastritis is it typically heals after several months. It's not a true chronic gastritis, hopefully, for most of our patients. We know that long-term NSAID use can create high risk for, gastritis, things like that. So a lot of the things we keep seeing are associated. The most common form of chronic gastritis is type B gastritis caused by H. pylori. Again, H. pylori wreaks havoc on our gastrointestinal system, so they'd be on antibiotics to kind of treat that. Where we're thinking about what we need to do, as far as prevention, it's the same thing: eating a well-balanced diet, regular exercise, keeping your weight where it needs to be, avoid excessive amounts of alcohol and, NSAIDs and corticosteroids and caffeine, all the stuff we've already talked about. Those things are not good for your gastrointestinal system. What you choose to put in your body is your choice, but just know that every action has a consequence, if you will. And this is kind of what's going on. What we think about with gastritis is be on alert for a rapid onset of epigastric pain, dyspepsia, or that burning sensation, heartburn, if you will. In some cases, they can even manifest with hematemesis, so they could have bright red bleeding or coffee ground blood. Melena is a word we hear about, dark, tarry, sticky stool. So those can be associated with gastritis as well. Just kind of keep an eye on your patients and look for signs and symptoms of bleeding, because that's really what we're worried about when it comes to gastritis. That's why we look at our eyes, nose, our daily weights, and vital signs, because we are worried about not just risk for fluid volume deficit through vomiting and things of that nature, but you could also bleed out as well. So it's important to pay attention to your patient's hydration status. Going into peptic ulcers. Peptic ulcers is when you have some kind of mucosa lining disruption. Pardon me. Typically because you have too much gastric juices that cause a hole in there, if you will. With peptic ulcers, what we typically end up seeing here is the melena. This is where it's a big thing. The minimal blood bleeding looks like occult blood in your stool. So that dark, tarry stool, that melena, is something that we typically associate with peptic ulcer disease. With these patients, it just depends on where we're at in the process. We have to worry about our patient and what's coming up next. So we know that the patient's more than likely going to have surgery. A lot of times they'll end up going to surgery. So preparing your patient for surgery is not a bad idea. Make sure you kind of understand what that process looks like. We want to do things to protect the lining of the stomach, so that stomach mucosa. So we're going to have to figure out ways to do that by giving medications, by avoiding certain foods. We need to give high doses of prednisone. Prednisone is going to cause that decreased inflammation process, so decreased inflammatory process. Those are what we know is going to happen as far as treatments are concerned. Get ready for surgery, giving medications to prevent the breakdown of further stomach mucosa. The high steroids. Know with these patients, like I said, it's typical for them to have this bleeding that looks like black tarry stool or dark tarry stool. Also, they typically wake up in the middle of the night, early morning, late night, between midnight and 2 o'clock in the morning. These patients will wake up, with epigastric pain because maybe a peptic ulcer could have perforated. If that happens, that will be a surgical emergency and it could be life-threatening. So with these patients, we need to be on high alert and watching for, physical manifestations and understand what our role is going to be. All right, so the next topic on our list is gastric cancer. Most cancers of the stomach develop in the mucosa, the mucosal cells after that form the innermost lining of that part of the stomach, if you will. In general, gastric cancer is more common in males than females. And typically over the age, there's a sharp increase in adults over the age of 50. So when you're getting to your mid 40s to 50s is when we really start looking at this, right? A lot of times there are no real symptoms in the early stages and the disease is advanced when people detect it. So that can be very problematic as well. Lots of different causes of this. We know that gastric cancer spreads by, direct extension through the gastric wall and into regional lymphatic system. So it's a pretty aggressive cancer sometimes, and it just kind of depends on when you catch it. Like I said, a lot of times you don't catch it until it's too late, or a lot later than what we should have seen. Early signs versus advanced gastric cancer signs. Early is always going to be the same things, that feeling of fullness, back pain, epigastric pain, abdominal discomfort relieved by antacids. As you get into that advanced cancer, nausea, vomiting, iron deficiency, enlarged lymph nodes, masses in your stomach. So you can start actually feeling if there's a tumor that were to go there. Non-surgical versus surgical things you can do, just really depends on how bad the cancer is. That's not really what our job is, to get in there. But we'll talk about malabsorption in a little while, which is a big concern with gastric cancer. We know that there's a lot of stuff going on with gastric cancer. We know that H. pylori is another one that leads to this. H. pylori is something you should be tested for, especially if you're having gastrointestinal issues. We've already seen it's been associated with multiple problems, and unfortunately those problems can end up leading to gastric cancer itself. We need to make sure that our patients are getting the adequate nutrition, small frequent meals again, reduce fluids in the meals so we don't get that full feeling and the patient will want to eat. They might need some kind of long-term B12 injections or other supplements to get them where they need to be. But what can we do about this? Not much. Like we're not going to fix the gastric cancer, but what we can do is try to prevent gastric cancer, which is our big role as a nurse. We need to understand what the American Cancer Society stresses as far as their guidelines. It's important for us to know that patients need to have either a sigmoidoscopy or a colonoscopy. The flexible sigmoidoscopy is every 5 years. Typically starting at age 45, right? So adults older than 45 need to have a colonoscopy every 5 years. They might also have a CT, which is a virtual colonoscopy, or they can do an acute blood sample. But the gold standard right now is still, people over the age of 45, especially if you have comorbidities, other things that diabetes, hypertension, things of that nature. You should definitely be going in and getting tested. The next one is irritable bowel syndrome, so IBS. Irritable bowel syndrome is a disorder that has a lot of abdominal pain associated with it, cramping. The risk factors, once again, are diet. And we know that foods high in fat that produce a lot of gas, those things can cause IBS, things like carbonated beverages, caffeine, alcohol. All of the stuff we know we shouldn't be eating that's not good for us and serves no purpose are the same things that cause our intestinal problems. If you really go back and look at your book, you can see that a huge majority of the problems in our book are self-induced. Smoking, stress, these things can cause issues as well. So knowing that anxiety and depression, all of these things can be a part of it. So when you're looking at NCLEX style questions and they're talking about stress and relaxation, those can definitely help with things like irritable bowel syndrome. As a nurse, one of the big things we're going to have to figure out is diet choices. If we know that high fat foods and things like that are what's causing our patient to have a flare up of their IBS, we need to do things like remind our patients about reducing stress, regular exercise, stop smoking if you can, but then focus on certain foods. You want to use some of the, if you can't use leaner meats, the white meats like your chicken and your baked pork, things of that nature. Fresh vegetables or even frozen vegetables, you want to try to avoid buttering them up too much or trying to make them taste like something they're not. So if you're looking for food choices, think about those lean meats that are baked versus fried. Think about some of your vegetables. Go with things like water instead of your caffeinated beverages or anything that has carbonation in it as well. All right, now we'll move on to obstructions. Intestinal obstructions, they can be partial, they can be complete blockages of the bowel. It could result in all kinds of stuff where you just can't get any of your content to pass through, which would be a bad thing. With obstructions, it just kind of depends on where the obstruction is and what kind of obstruction it is. We know the signs and symptoms would include bowel distension, maybe some hypo or hyperactive bowel sounds. It kind of depends on where we're at. The two big ones we talk about is mechanical versus non-mechanical obstructions. It just depends on where we're at. In mechanical obstructions, the bowel is physically blocked by some kind of problem outside of the intestine itself. It could be an adhesion in the bowel walls. It could be Crohn's disease. It could be a tumor. That's what a mechanical obstruction is. There's physically something blocking it. A non-mechanical obstruction, on the other hand, could be like a paralytic ileus. After surgery, they've given you a lot of medication that might have slowed down your peristalsis, right? Those things. It does not involve a physical obstruction in or outside of the intestine itself. Instead, it's just decreased movement of your bowel, so it could be neuromuscular disturbance, something like that. Intestinal contents are includes your food and your fluid and saliva and all kinds of stuff going on there. So we need to make sure that we keep that going on. We know complications of intestinal obstructions run the gamut. Fluid and electrolyte imbalances are huge since we absorb a lot of our electrolytes in the bowel itself. You can think about potassium and stuff of that nature. So if we're not absorbing it and it's just going through, we could have a huge imbalance, fluid and electrolyte imbalance as well. So that can be problematic, especially when we're thinking about some of the important electrolytes. Surgery may be needed to relieve the obstruction if you can't decompress the gastric symptoms, if you can't relieve the symptoms. Or if there's any kind of signs of bowel necrosis. If you're not getting any blood flow to your bowel and it causes necrosis, of course it will die, and then you're in a whole different world there, which then could creation of an ileostomy or a colostomy or something like that. So we need to be constantly assessing our patients. That's the nurse's job. Your job is to assess. Assess for the peristalsis, right? Auscultate the breath sounds. We know that non-mechanical obstructions typically equal no bowel sounds, right? If you have a non-mechanical obstruction, there's a neurological problem, there's medication involved here, you wouldn't hear bowel sounds, or very hypoactive, but typically the absence of bowel sounds. If it were a mechanical blockage, you could have a lot of movement on one side or the other because you're trying to get it around. So you might have some hyperactive bowel sounds, before you get to the obstruction itself. So kind of think about the things that you need to be aware of. When you move on to intestinal obstructions, there's a small bowel versus a large bowel obstruction. When I think about small bowel obstructions, if the small bowel obstruction is complete, the waves become very vigorous. You would have a lot of movement trying to get past that blockage. Unfortunately, if you can't move your content past the blockage, where is it going to go? It's going to move back up towards the opening of the digestive tract. So instead of coming out of your rectum, the contents will be pushed more towards the upper portion, and you might have patients who vomit fecal matter, right? So it's not uncommon to have fecal matter come out of the mouth in a patient who has a small bowel obstruction. Just in the abdomen, bloated sensation, things like that are things you need to be paying attention to. These patients might end up having some kind of ostomy to clear the blockage. They might need to have some, diversion of the content. So they could end up getting an ileostomy. And ileostomies, even though you have an ileostomy, you have an opening outside of the stomach now, there's still a bag that retains a lot of it. So part of your job now is to think about talking about teaching your patient about emptying the pouch when it's 1/3 to a half of the way full, right? You never want to wait until it's halfway full to, almost full, because as that gas starts to increase, it could burst the lid or the top off of your ostomy bag and create just a huge mess. So make sure you understand what your role is. If the abdomen stops draining, if the ileostomy itself stops draining, there are things you need to teach your patient to do. Have them massage the abdomen, see if they can get the drainage to going. Have them drink hot liquid if they start having abdominal cramping. It could be, tea or, decaf coffee or warm water. It doesn't really matter. Just something that's warm that can help get the movement again. And then make sure that they're changing out their actual pouch system, at least weekly, 1 to 2 times a week. They need to change the whole system out. It doesn't have to be done daily, but they should be, draining it when it's about 1/3 of the way full. Never more than a half of the way full, because that's when you start having problems. So that's kind of there. Large bowel obstructions, we're talking about constipation, might be the only symptom you have, but you just can't get anything out because you have a large bowel obstruction. What you might end up seeing is something called ribbon-like stools, where the poop is trying to get, or the fecal matter is trying to get around that obstruction in the large bowel. So the pressure behind it starts to build, and it starts to squirting. It starts squirting fecal matter around the blockage. So you can get these ribbon-like stools when you have a large bowel obstruction. So, think about what you're looking for and what you would expect your patient to present with and what you can teach your patient as far as, lifestyle changes to avoid further issues. Okay, appendicitis is something that I'm sure we're all familiar with. And it's just it's inflammation of the appendix. Usually in younger adults, among young adults is where we see it most commonly. And it typically presents in the right lower quadrant more than anywhere else. So we know that the appendix, extends off of the proximal cecum of the colon. So that's why it's in that right lower quadrant. Kind of depends what's going on. It could be some kind of blockage leading to an infection. And then you have the pus buildup in the appendix itself. So those are some issues that we're having that we have to kind of think about. In an appendicitis, that lumen is typically blocked, and like I said, it restricts a lot of pressure. It restricts the blood flow, which results in pain. The problem is that it can start to cause severe blood flow problems, right? You can get gangrene and sepsis within, just a day or two. It's super important that when your patient starts presenting with signs and symptoms of an appendicitis, that we do something about it. So how do we know if our patient's having, signs and symptoms of an acute appendicitis? It depends on where the pain is. So there's things we're going to do. We know that history taking is going to be the most important thing you can do. That's what we do, y'all. Assessment is the name of the game. That's why the nursing process starts with assessment. So you need to start thinking about inflammation, infection. That kind of process is going to cause pain. It's going to become more and more severe as time progresses. So that right lower quadrant area in between like the iliac crest and the umbilicus itself is where you're going to start thinking about pain. They call that the McBurney point. It's figure 52.1 in your book. But abdominal pain that increases with coughing or movement and is relieved by bending your right hip or the knees, that suggests that you have a perforation or some kind of peritonitis. That is super, super important for us to understand. We know that the primary health provider was also going to assess for what's called muscle rigidity and guarding when they palpate the abdomen itself. Typically, the patient's going to have some kind of pain after the release of pressure. So this sensation is something that we call rebound tenderness. So we know when we're looking at patients who may be experiencing an acute appendicitis, we're looking for those things. We're looking for pain that gets worse and increases with coughing and movement and is relieved by bending those knees and those hips up. And then when they release that pressure, it hurts again. So that rebound tenderness. That's what we're talking about when we think of our appendicitis, if you will. The next one is called peritonitis. It's all part of the same thing. Peritonitis is just when you get contamination of, that peritoneal cavity. It becomes dirty. It gets bacteria or chemical irritant. If you have a ruptured appendicitis, the appendix ruptures, it could cause a peritonitis. Just acute abdominal pain that's an abrupt onset because it just happens very quickly. Assessments, all we're going to do with these patients, we're going to continue to assess. We're going to continue to look for, signs and symptoms. There's an issue. Depending on the signs and symptoms, we might need to do nasal gastric decompression so they get an NG tube. They might need to get some fluids and even blood products because if they are bleeding out, then that could be problematic as well. Gastroenteritis is very common. Worldwide, it causes diarrhea and vomiting related to the inflammation of the mucosa membranes of the stomach and the intestinal tract itself. It's commonly affected by some kind of viral type issue, which is more common, or some kind of bacterial infection. But gastroenteritis is the inflammatory process, is inflammation of your gastrointestinal tract. We know that the norovirus is the leading foodborne disease that causes gastroenteritis. So once again, these are things that a lot of times are preventable, right? The major clinical manifestations are going to be diarrhea, of course, and as you have diarrhea, we know that potassium is absorbed in the intestines. So if you're having severe diarrhea, not only will you have metabolic acidosis, you're going to have hypokalemia as well because you're not going to have the ability to absorb the potassium where you need to absorb the potassium at. Abdominal pain and cramping just kind of makes sense, right? So what do we need to worry about? Well, if we know that our patient is going to be spilling out all of these electrolytes and stuff, then monitoring for electrolyte imbalances once again is going to be huge. We know the associated clinical manifestations, nausea, vomiting, fever, all that kind of go with it. The borborygmi, the hyper bowel sounds and stuff, because you're getting rid of things. But monitor for things like cardiac dysrhythmias. You know, if you're going to be hypokalemic, that you run the risk of having some electrolyte imbalances, and then that could also lead to something, like I said, a cardiac dysrhythmia. So is there anything you're going to do to prevent the gastroenteritis yourself? Probably not. You're going to get the patient there. We can talk about things to help them get better, but if it truly indeed is, bacterial, then we can give antibiotics. If it's viral, we're just going to have to support with fluid and monitor the electrolytes, make sure that we replace whatever is low to prevent any kind of dysrhythmias or cardiac problems as well. Inflammatory bowel disease is another topic we're about to get into, and then we'll follow in with Crohn's disease. IBD is two different chronic diseases, right? It's ulcerative colitis and this Crohn's disease. So I won't spend a lot of time on this one itself. We'll pop into Crohn's disease and ulcerative colitis and kind of look at the differences in the manner in which they affect the digestive tract. That's what we'll do here. But know that you as a nurse, you have to think about dietary modifications, nutritional status. These patients need to go to some kind of a dietitian. So you need to do referrals and delegate some of this, meal planning to your dietitian. Think about the same thing we've been talking about: lean meats, high protein foods that aren't meat, low in fat, water versus alcohol or beverages or juice or anything else. The things you're supposed to be ingesting anyway, right? Think about maintaining high fluid intake and manifestations, that are associated with diarrhea. If you have IBD, ulcerative colitis, or Crohn's disease, you can have, what we consider, dumping syndrome on some people. So we have to worry about that with our patients. We know the treatment for these patients is to decrease the diarrhea. That way we can help increase nutritional intake and help the patient gain weight and reduce any kind of elimination complications as well. So continuing along this path, we know that Crohn's disease is chronic inflammatory disease, right? Typically the small intestines and the colon are both, most common in the small intestines, but it can affect the GI tract from mouth to anus. It really doesn't matter where. It can happen where it happens. So what is Crohn's disease? Like I said, inflammation that causes your bowel wall to be thickened. They have all kinds of stuff, cobblestone appearance. We don't really look at that unless you're doing, x-rays and things of that nature, but they can cause a fistula or an abdominal opening in, between two organs. So that can be a problem as well. Diarrhea, malabsorption, those are big things once again. Typically the patient has some kind of, once again, some kind of infection that needs to be treated. And that's really where the problem is with these patients, having to get that treated. What do we do with our patients who have, Crohn's disease? A lot of it's going to be diet and exercise, once again, trying to do certain things. But we know that our patients are going to be on some kind of medication. If you get into your book, they have patient-centered care. Depends on what you're looking for as far as geriatrics versus not. But, you are going to have to think about your patient as far as nutrition and hydration status. Those are things you have to always be cognizant about, right? When you're inspecting the abdomen, look for that distension and masses. Look for any kind of visible peristalsis. You're looking for increased movement in the stomach there. We know that abdominal pain from inflammation is usually constant and in that right lower quadrant as well. So people kind of can mimic what they are. But what are we worried about with these patients? There's a lot. Like I said, one of the non-surgical management things we're going to do is give these patients medication. They're on what's called BRMs, these biological response modifiers. Get in your book, it's in page 1146 under non-surgical management. Look at some of these drug names. These are probably some drugs you're not real familiar with. It's just something that unless you work with these patients on the daily or you have Crohn's yourself, you're probably not going to know about the monoclonal antibody drugs and things like that, part of the BRMs, and what they are and what they do. So we know with these patients, they're going to be on some of these medications. So we have to understand they're going to be getting injections. So we need to look for injection site issues, look for any kind of inflammation there, or swelling, redness, things of that nature. Pay attention to your patient. Medical management of ulcerative colitis is if it's not successful, surgical intervention will have to happen, and they usually end up getting an ostomy. So we're going to try to do everything we can do not to get that ostomy. If a stoma is created in the abdomen, then we need to think about that as well. As far as emptying the bag, a third to halfway full. Apply skin barrier cream to the part that might come in contact with fecal matter. We don't typically put that cream or that barrier directly on the stoma itself. It just depends on what we're doing there. Just pay attention to what your job is. Understand that if your patient has Crohn's and then all of a sudden they have a large emesis that has fecal matter in it, that would be some kind of bowel obstruction, that it can't go further down. That is going to be life-threatening if we don't do something about it, because they could aspirate that into their lungs and cause even further infection. So that's kind of Crohn's disease. On the other hand, you have ulcerative colitis. This one typically involves the large intestines, whereas Crohn's disease is a lot of times more in your small intestines. Your ulcerative colitis a lot of times is large intestines. Once again, they can be on either end of the spectrum from opening to opening. This is just what's typical presentation. With ulcerative colitis, it is different, but it still falls underneath that same umbrella, if you will. So when we're trying to do we need to differentiate the two? Not necessarily here for our exam. You're going to have somebody tell you what's going on with your patient anyway, what they have as far as a diagnosis is concerned. But we're really going to be looking at the signs and symptoms once again of what we can do as nursing. As nurses, what can we do? So monitor your patient with ulcerative colitis once again for loss of fluids. Look at electrolyte imbalances. These are going to be very important. Patients are going to report weight loss, anorexia, fatigue, weakness. These people are typically going to have volume loss as well, right? So get diagnostic studies that include getting the CBC, looking for anemia. Make sure you're checking their fluid electrolyte balances for hypovolemia. Super important. Check their serum albumin levels and folic acid levels. You need to make sure you're looking for signs and symptoms associated with nursing diagnoses outside of this. So ulcerative colitis, one of the big things that we're going to worry about is that evaluation of your electrolyte levels and look at your fluid volume so we can kind of figure out what we need to do next. The next disease process we're going to talk about is diverticular disease. So the diverticula, these are these little pouch-like, herniations throughout the muscle wall of the abdomen, right? They're most common in the colon. So that's what we're talking about, diverticula. Diverticulosis is the presence of many abnormal pouch-like herniations. So the diverticula. That's what diverticulosis is. Diverticulitis is the inflammation or the infection of these diverticula. So some people have, we have diverticula in our body. Diverticulosis is the presence of abnormal pouch-like herniations. So you're going to have an excessive amount. That's what diverticulosis is. Diverticulitis is the actual inflammation of the diverticulose. So it can be confusing on some levels, but just understand what it is. You have an inflammation of a part of your large intestines now, of your colon. That's all you really need to know. That tells you a lot of stuff. Are you going to get good absorption if you have that? The answer is no. So we know that the muscle of the colon, it starts to hypertrophy, it thickens, it becomes rigid, there's herniation of the mucosa. Diverticuli occurs at points of weakness in the intestinal wall itself. So this is typically a part of the aging process or because of lack of fiber in your diet. So if you're not eating your fruits and vegetables and your grains like you're supposed to, you put yourself at risk for diverticulitis and diverticular disease in general. So that's kind of where we're at with this. It's a big process, if you will. Diet, exercise, once again, these are huge components of teaching you as a nurse what you have to talk to your patients about. So you're going to have to recognize cues, of your patient, what they have going on. We know that diverticulitis typically have abdominal pain, most often in the left lower quadrant, because that's where your colon is. And that's what we're looking at. But what can you do about it? Once again, non-surgical management, nutritional therapy with rest is used to decrease the inflammatory process of the diverticular disease. They'll give broad spectrum antibiotic drugs, antimicrobial drugs. They might need those as well. But typically, you as a nurse need to think about diet. What can you do as far as diet is concerned? And then what kind of diet stuff could you think about? Once again, it's going to be your lean meats, lack of fat, like your grilled chicken breast. With diverticulitis, we need to think about things that can get stuck in the diverticulum itself. White rice, not a problem. That is a food that is easily digestible. So even though it's small, a lot of nursing students kind of confuse that and think that that is something that may be problematic. But we're looking for things that can get stuck. So go back into your book and really look in there at some of the food choices that exist that should be avoided. Like I said, there's some good NCLEX style questions, and there's a 52.3 has a good question. But go in there and look and see what kind of stuff you need to be eating. I think it's on page 1150. It talks about patients with diverticular disease need education on their high fiber diets, right? If you have diverticulosis, you should eat a high fiber diet and cellulose and other things in fiber. These substances are, like I said, in wheat brands and whole grain breads and cereal. They need to eat a lot. Fresh fruits and vegetables, those have to be there to help bulk up your stool. So start thinking about how you're going to talk to your patient about this. Now, a patient should be instructed to avoid all fiber when symptoms of diverticulitis are present. So when you have diverticulosis, of course, we want to have this increase in bulk food and high fiber to get them to poop and get things going on. But when you actually have diverticulitis, high fiber foods are irritating. As inflammation resolves, fiber will gradually be added back in. So diet's going to be huge with these patients. High fiber diets when they're not having an actual flare-up of diverticulitis. But when they do have an actual flare-up, we're not going to go with the high fiber foods anymore because it can be very problematic to our patient and just perpetuate the problem. All right, hepatitis is on our list as well. Hepatitis, in your book, says this, right, like it says here on the screen, a widespread inflammation of the liver that results in the degeneration and necrosis of liver cells. That tells you everything you need to know about it. Your liver is not going to work anymore, right? So we know that hepatitis can be caused by many, many things. Hepatitis can be acute or chronic. It just depends on what we're having. Viral hepatitis for sure. Least common types of hepatitis are caused by chemicals, drugs, and some herbs and things like that. But viral hepatitis results in an infection caused by one of the 5 categories of the virus we have. We know we have hepatitis A, B, and C, which we're all familiar with. But there's also hepatitis D and E. We know that some cases of viral hepatitis are not caused by these viruses, which we understand that. But we're talking about the big stuff. There's a lot that can go on. We need to know how hepatitis is passed. So you can get into your book and you can look at each one of these specifically. They'll give you really good insight onto, what exactly is being, how it's transmitted. I'm sorry, I'm trying to figure out what I'm doing here. We know that hepatitis A is typically that fecal to oral route. So, you get somebody's fecal matter on their hands. They don't wash their hands after they come back from using the restroom. They prepare food. You end up getting hepatitis A. Not a good thing. Hepatitis B, typically transmitted by some kind of, blood stuff. So think about a patient who is getting a blood stick. You're doing a blood transfusion. You pull out the needle. You stick yourself. The possibility of getting hepatitis B transmission is greater that way. Or if you're using equipment that is not cleaned properly, it could be surgical equipment or a cystoscopy, hemodialysis. If they don't clean those machines correctly and they don't sanitize them correctly to get all of the bacteria and the viruses killed, then you could potentially transmit hepatitis B that way as well. Hepatitis C, this is another one that is typically via blood. It could be sex as well. we know that a lot of times with these transmitted via blood, blood to blood, sharing drug needles, needle sticks, unsanitary equipment, like we said, as far as tattoo equipment, things like that. Blood to blood. Hepatitis D, that's transmitted via sexual contact. Hepatitis E, that's transmitted by contaminated food. So I won't go into a lot of different things about hepatitis because it's just such a big, broad topic. But what you need to know for yourself is how they're transmitted and what we can do to avoid transmission and what we can teach our patients as far as what, concerning how to prevent the spread of hepatitis. And the best way is knowing how to contract it in the first place. All right, gallbladder problems. A lot of folks have gallbladder problems in life. Cholelithiasis, so gallstones, they develop due to inflammation within the gallbladder itself. Cholecystitis is the inflammation of the gallbladder. We know that people who have gallbladder problems typically present with some kind of abdominal pain. A lot of folks who come to the ER think they're having a heart attack because this is epigastric abdominal pain, kind of high up. We know that that is very problematic, and people will seek immediate attention for this because it is scary and it is very painful. So like I said, there are different types that are associated with this. We know that you can have, the most common type is cholecystitis, which is that chemical irritation or inflammation of the actual gall bladder from gallstones, or calculi, the cholelithiasis, that's the obstruction in the cystic duct. So there can be different things. It depends on what causes it. A lot of folks who have gallbladder problems end up having a cholecystectomy, usually like a lap chole, where they go in there and remove it laparoscopically. So that's typically what's going to happen with a patient who has gallbladder problems. They'll just go in and remove the gallbladder itself. Like I said, that is where a lot of our patients are going to have things. So cholecystectomy is when they remove the gallbladder itself. It can be open, which is not typically what we do anymore. The gold standard now is going to be the laparoscopic cholecystectomy or the lap chole. It's definitely preferred because the patient has just 3 little holes in their stomach. They inject some air into the abdominal area again to kind of open it up, so you can kind of see what's going on with the patient. What you kind of need to be cognizant about is when your patient has surgery or has the procedure, follow up with them. Make sure the patient knows that they need to call their doctor if they're having abdominal pain, a couple of days after the procedure. They can have episodic upper abdominal pain that just kind of comes and goes. So it's going to be important for you to know what to talk to your patient about. If they go in and have the stones removed, make sure they understand what that looks like. If after the procedure, it could take a few days for them to see some of these episodic upper abdominal pain type manifestations that you need to be on the lookout for. Make sure that afterwards you need to talk to your patient about the biliary disorders and how dietary is going to affect this. Let patients know not to skip meals, right? And to exercise regularly. But the foods that are not well tolerated are typically a lot of your fat-filled foods, your eggs, porks, onions, poultry, milk. A lot of these things can be very upsetting to a person who has gallbladder problems or who have had a cholecystectomy. Once you lose your gallbladder, the gallbladder helps with the breakdown of fats in the body. So when you're eating high-fat foods, a lot of people who have a cholecystectomy will end up having dumping syndrome and kind of have an issue keeping food down altogether. All right, just a couple more slides and we're done. Malnutrition. This really applies to most of these disease processes. So these malnutrition is a complication associated with all kinds of stuff. It just depends on what's going on, but it looks like muscle wasting. Your patient's going to be lethargic. They're going to have the inability to tolerate cold, a lot like your patients who have like hypothyroidism, where everything's slowed down because they also have that associated with malnutrition or malabsorption, dry skin, things like that. So you need to pay attention to your patient's nutrition status. You and I have already talked about this multiple times. We know that nutritional status is greatly determined by your total protein levels. And we know we measure total protein by looking at prealbumin levels. This is definitely the best indicator for the client's nutritional status. Prealbumin levels, make sure you go back and look and see what they should be. If you notice that your patient's prealbumin level is low, but then it starts to get better, that is a good sign and symptom that your patient's nutritional status is starting to improve. So make sure you're talking to your patients about this. Make sure you know what you need to look for, that you're looking for total protein, if you will. If the patient's able to consume food by themselves and they can eat enough by mouth, great. That's exactly what we're hoping for. We always want our patients to get their nutrients by mouth on their own. It is the best way to be absorbed. Otherwise, we're going to go into total internal nutrition. We call that TEN, or total parenteral nutrition, where we give you like tube feeding. It's one method that we use to get people the nutrients they need. Once again, we don't want to put anything directly into your GI tract because it doesn't get absorbed as readily. However, it's a better option than not. Lastly is going to be obesity, which is a part of this topic as well. And when we talk about obesity, we're not just talking about somebody who's slightly overweight. We talk about people who have a BMI above 40. Like it's quite problematic to the point where it's causing hypertension and diabetes and other portions, other life-altering events. This comorbidity of obesity is a pandemic in itself. So we know that people who have obesity, a lot of times they're going for bariatric surgery to treat it. If they have, a BMI that's really high, they usually get some kind of laparoscopic adjustment. They get a lap band around their stomach that creates a small pouch so they don't eat as much. There's not a lot that we talk about on this. I would say for you, what is your job, if you will? We know that these patients are going to be on clear liquid diets, slowly introduced like anything else, and then we'll move our way up to pureed, then juices, soups. We just keep getting thicker and thicker. Leaks are very common after surgery, so manifestations are pain in the back and shoulder, like anything else. If you had a bowel, leakage, you would feel that. They'll be using abdominal binders over their dressings to prevent any kind of adhesion post-operatively. So for these patients, it's important for them to know to wear their binder until the doctor says it's okay to come off. And then look for signs and symptoms of dumping syndrome after some kind of gastric bypass. Typically, they're tachycardic, nausea, diarrhea, and abdominal cramping. They should also eat small meals daily to help prevent any kind of dumping syndrome as well. So that's really all we have on this week. If you have any questions, make sure you refer back to your book, look at the syllabus, and use that as your blueprint. It'll tell you exactly what you need to know and where to look. Good luck.